Thank you for joining us for today's program titled Practical Pearls on ASCVD and Lipid Management. This educational program is sponsored by Novartis Pharmaceuticals Corporation, Novartis, and the physicians were compensated for their time. Opinions of the physicians are their own. Today's speakers include Dr. Ijeoma Isiadinso, an associate professor of medicine within the Division of Cardiology at Emory University Hospital in Atlanta, Georgia, and the director of Emory Center for Heart Disease Prevention, Dr. Karol Watson, a professor of cardiology and director of the Barbra Streisand Women's Heart Health Program and co-director of the program in preventive cardiology at the University of California, Los Angeles, and Dr. Willa Hsueh, director of the Diabetes and Metabolism Research Center and professor of internal medicine at Ohio State University College of Medicine. We will now begin today's program.
Hello and welcome to this Novartis program. I am Dr. Ijeoma Isiadinso from Emory University Hospital in Atlanta, Georgia. I am an associate professor of medicine within the Division of Cardiology, and I also serve as the director of the Emory Center for Heart Disease Prevention. Joining me today in this discussion are my two colleagues, Dr. Willa Hsueh. She is the director of the Diabetes and Metabolism Research Center and professor in the Department of Internal Medicine at the Ohio State University College of Medicine. Dr. Karol Watson also joins us. She is a professor of cardiology and director of the Barbra Streisand Women's Heart Health Program and co-director of the program in preventive cardiology at the University of California, Los Angeles. Today, our panel of experts will review the important connection between atherosclerotic cardiovascular disease and hyperlipidemia. We'll focus on the unmet needs in the management of LDL cholesterol and how these translate into suboptimal outcomes in patients with ASCVD, with a special focus on women and underserved inner city populations. Thank you very much, and we'll begin with our discussion. Let's start with the basics. Dr. Watson, I'll start with you. What is atherosclerotic cardiovascular disease?
So atherosclerotic cardiovascular disease, which we always abbreviate ASCVD, is any vascular disease that has atherosclerosis at its basis. So in terms of morbidity and mortality, most of heart diseases do have atherosclerosis at their basis. Those are all atherosclerotic cardiovascular diseases, ASCVD. The two we think of most prominently are stroke and myocardial infarction. And what we know now is that anytime you have atherosclerotic plaque, that plaque can become vulnerable and rupture open. When it does that, plaque content starts to see circulating blood, things they're never supposed to see, like prothrombotic factors, tissue factor, things like that, and a clot forms. So then you can have cessation of blood flow, and that causes an acute clinical event, a heart attack or a stroke. And that's what ASCVD, atherosclerotic cardiovascular disease is.
Watson, you hit on a couple of things like plaque rupture in highlighting some of the pathophysiology of ASCVD. Dr. Hsueh, I'm going to turn to you now. How do lipids play a role in pathophysiology of ASCVD and the plaque development as well?
Well, I think lipids are one of the most important factors that are contributing to ASCVD. As you know, cholesterol is very, very important. And in fact, cholesterol, especially low density lipoprotein cholesterol, which should be cleared by the liver, when it's inappropriately cleared, the cholesterol particles get into the vessel wall, the subintimal spaces. And this is followed by inflammation, especially with macrophages. Then macrophages, the monocytes, when they enter the vessel wall, become macrophages. The macrophages try to gobble up the extra lipid, the cholesterol, but they get full of cholesterol. When cholesterol levels are high, they break down, and this leads to a necrotic lipid core, which is inside the plaque. And this necrotic core is causing massive amounts of inflammation inside the plaque. Now, the reverse cholesterol transport pathway, which is mediated by what we call phagocytic macrophages, are trying to take this out and turn it, put it into HDL cholesterol. But if HDL cholesterol levels are low, you can't remove this excess cholesterol, and these necrotic lipid cores continue to grow, inflammation continues, and then you can have this plaque rupture that Dr. Watson so amply described.
That's a great description, Dr. Hsueh. And can I piggyback on what you said? Just like you mentioned, all of the cardiovascular risk factors, hypertension, hyperlipidemia, diabetes, age, smoking, etc., they're all important. They all help grow the atherosclerotic plaque. But I've always said there really is only one risk factor that is absolutely essential. And you cannot actually get this atherosclerotic process to start unless you have an abnormal lipid particle that can enter the artery wall, that can get engulfed by the macrophages, like you say, and start the whole process. So they're all important. I agree with you that the most important may be dyslipidemia.
Yes, I would agree. And I think it's this balance between LDL and HDL, which determines not only how much plaque you get, but if you can relieve plaque burden. And so there's always this balance that we're trying to fight with in terms of lowering LDL and increasing HDL.
You're both absolutely right. Certainly our lipoproteins play a significant role in the overall process. One of the things that I struggle with patients, educating them, is about the risk factors. They all know about cholesterol, and a lot of them focus more so on their diet being the source of elevated cholesterol levels, but there are other risk factors for ASCVD. Can either of you discuss that?
Carol, you want to start?
What specifically would you like me to discuss?
Can we review, just to start with, what are the risk factors for ASCVD, both the traditional and non-traditional risk factors that as clinicians we should be aware of?
Yeah. So exactly as I just mentioned, the traditional risk factors are typically thought of as age, race can be considered one, gender, either males after the age of 50 or females after the age of 60, or postmenopausal females. Then things like diabetes, hyperlipidemia, hypertension, poor diet, lack of physical activity. These are all classic cardiovascular risk factors. What we're understanding now is there are some more emerging risk factors, maybe things like pregnancy history, rheumatologic disease, etc. So there are probably others that are going to be joining our cadre, but the traditional ones are the ones I mentioned first. And as I mentioned, of those, I think dyslipidemia has a special place because it really is necessary for atherosclerosis to begin.
Mm-hmm. So I think that if you have the cholesterol, these other things amplify the formation of a plaque, much of which I think is related to inflammation and alterations in the immune system. And my patients, unfortunately, have obesity with and without diabetes. And I think obesity in and of itself is clearly a risk factor. So along with obesity, and sometimes again with and without diabetes, I see patients with non-alcoholic steatohepatitis. And our GI colleagues have called this atherosclerosis of the liver. I'm not sure I go that far, but certainly there is an epidemiologic association between NASH, non-alcoholic steatohepatitis, which goes on to cirrhosis of the liver, and atherosclerosis. So I think those, to me, when I see a patient with NASH, so most obese patients have steatosis, liver fat, but about 20 to 25% of them will go on to have inflammation, which is key. And that inflammation can go on to fibrosis or cirrhosis. And I had a patient today who has cirrhosis of the liver from obesity associated with diabetes, and she's begging for a referral. This is a new patient for me, a referral to a liver specialist because she's really got end-stage liver disease. And I'm sure she has atherosclerosis, but we're working up her NASH.
You bring up a really good point with the inflammation. So as I said, I really do think dyslipidemia is the great risk factor that's eliciting and starting the atherosclerosis process. But as you said, all of our cardiovascular risk factors are pro-inflammatory. And when you think about it, so the LDL cholesterol has to get into the artery wall. And the endothelial barrier is a really good functional barrier. It's really only when you get endothelial dysfunction or injury that you can actually start to see a lot of LDL enter the artery wall. And if you have every single risk factor that you have compounds on itself and increases the inflammation. So if you have a lot of inflammation around, you're going to get a lot of endothelial dysfunction, and you're going to allow a lot of LDL cholesterol in. So it's not just that these risk factors are bad in and of themselves, they are, but they're also bad in the inflammation they elicit.
Yeah, that's great because many of these risk factors are associated with endothelial dysfunction. So that's obesity, diabetes, hypertension, hyperlipidemia itself. All of these disrupt the endothelium, which is where this inflammation and all this vessel unhappiness starts.
It's important to understand that association because all of the risk factors you just mentioned, Dr. Hsueh, are all preventable. So if we can prevent these risk factors from the onset, you don't go down that pathway of endothelial dysfunction, then the development of atherosclerosis. So very important for sure.
Absolutely. You know, we follow here, we practice. I usually have my sign up, but somebody stole it. It's Life Simple 7.
Yeah.
Yes, of the American Heart Association. So we try to practice that, not just amongst ourselves, but I hand the little Simple 7 page to my patients.
Let's recap what we learned in Part 1. Elevated LDL-C is a leading risk factor for ASCVD, and guideline-recommended levels should be obtained to reduce risk of CV events. People with CVD, or who are at risk for CVD due to the presence of one or more risk factors such as hypertension, diabetes, hyperlipidemia, or already established disease, need early detection and management using counseling and medicines as appropriate.
One thing I wanted to make sure the audience was aware is that you both have very unique populations that you see, patient populations. Dr. Hsueh, you touched on this a little bit when you mentioned that you see a lot of patients with obesity and diabetes. I understand that you see a lot of patients from Mexican-American background. Can you tell me the prevalence of ASCVD in your patient population?
Well, when I was at UCLA and when I was in Houston, I saw a lot of Mexican American, especially women, with diabetes. So they have one amongst the highest incidence of type 2 diabetes of all ethnic and gender groups in the United States. Now, interestingly enough, I've moved to Columbus, Ohio, where I see a lot of African American women, and they've actually, in the transition of my move, have now they have the highest incidence of type 2 diabetes of any ethnic gender group in the United States. So it turns out what I've seen is that the African American women with diabetes have a higher incidence of atherosclerotic coronary vascular disease than even the Mexican American women. Wow. So they both have, like, in our it's shocking, in our population of African Americans in Columbus, Ohio, of the ladies, people who are over 50 have almost a 70% incidence of type 2 diabetes. It's rampant and a huge incidence of diabetes. And probably half of those people have bona fide atherosclerotic coronary vascular disease, or have had an MI or bypass or something.
And remember, we have to keep straight. There are people with ASCVD, and they may have chronic stable angina or just a TI or something. But then there are people who have real acute coronary events, plaque rupture, big MI, big stroke, something like that. And as we were been talking about inflammation, it underlies not only the initiation of atherosclerosis, the progression of atherosclerosis, but also the transformation to clinical events. So that all those risk factors we talked about that increase inflammation, they all increase the risk of plaque rupture. So if you have a lot of LDL cholesterol floating around, that plaque's going to start earlier, grow faster, and be more likely to rupture, leading to an acute event. And as we talk about racial and ethnic differences in presentation, it's probably true that the inherent baseline inflammation in populations also affects their risk of going on to an acute event.
So when you say inherent inflammation, are you talking about ethnic differences in inflammation?
Yeah, so if you look at baseline CRP levels on any average Tuesday in groups of population, African American women have higher CRP levels than other populations. But
is that for age and gender matched?
All of it is controlled for all risk factors. It's higher, and there's muscle mass, everything is higher.
Even their weight.
Control for every
baseline
risk factor.
Oh, that's interesting, because their weight distribution in African Americans, this is very interesting to me. They supposedly have more sub-Q adiposity as opposed to central adiposity or visceral adiposity, and in terms of metabolic syndrome, the African American population has less triglycerides because their liver seems to synthesize less, convert less fatty acids and have less de novo lipogenesis. However, the African American population is at high risk for coronary artery.
Exactly, and we think
the distribution of the
we think a lot of this relates to inflammation.
Yes, yes. So it's interesting what you say about CRP. So that they have more underlying inflammation. It would be interesting. We do adipose tissue biopsies at bariatric surgery, and certainly we found lots of pro-inflammatory immune cell changes in obese people versus lean people. And we're trying to get enough samples so we actually could compare African American adipose tissue compared with Caucasian adipose tissue. We don't have too many Hispanics or Asians here, but that might be interesting to look at that. Yeah.
Actually, Dr. Watson, knowing that correlation between CRP levels in African American women, how often rather do you use CRP in CV risk stratification or risk assessment in your patient population?
It's a good question, and consistent with the new ACC/AHA lipid guidelines, I use it as a tiebreaker. So if there's someone who I'm on the fence about how aggressive to be with risk modification, that can tip me over. If it's elevated, I say I need to get the LDL way down, or the blood pressure even lower. If it's normal, I can feel a little less compelled to be as aggressive. So it's a decision tool that can be used to help you decide how intensively to modify risk factors.
One other thing I wanted to touch on is we talk a little bit about the risk factors as well as the pathophysiology of ASCVD. We understand that therapeutic lifestyle changes are the cornerstone of cardiovascular disease prevention. How do you engage your patients in this discussion, especially when there may be some limitations about ability to participate in exercise or find healthy foods within the individual communities? Dr. Hsueh, you want to start?
Well, actually, coming from an agricultural community, I think it's kind of changed our perspective here. Mm-hmm. So actually, our population in our outpatient center is about 40% African American, and then probably about 50% Caucasian with 10% of others. But so we have actually talk about, the specific diet, the specific eating habits, number one. Number two, we actually have vegetable gardens outside of our outpatient center, and we also have gardens on campus that we encourage patients to participate in and try to eat healthier foods. And we also work with our food bank, trying to get them to supply fresher foods rather than prepackaged stuff with all kinds of preservatives in them. So we've been really trying to work within the community. So it kind of works. And then we have an army of nutritionists that also help us working towards this goal. So I think you really have to understand the individual lifestyle and that person to try to really be able to help. And then when I was in Houston, we did the same thing with the Hispanic ladies, and we had food classes where they actually talked about presentation of Hispanic-based food, cut down on the lard, and how you can cook healthier. So we do the same thing with African Americans now. So I think that's an important part, is to individualize, to know your community, to have community advocates and work with them. And we also have a special liaison with the Health Disparities Commissioner here in Columbus. And we're very lucky because if we find that something works, she will help to get this on a major agenda for the state and potentially get this approved and pay for some of these things by the state of Ohio. So I'm very happy that we think we can actually accomplish changes in lifestyle.
Yeah, that's amazing. Some of those efforts that you're describing, you've been able to accomplish.
Yeah, our division got an award, our endocrine division, for the best vegetable garden, believe it or not. But that was including, dependent not only on the faculty, but our patients had to be involved in that.
Dr. Watson, what about other lifestyle strategies that you may discuss with your patients?
So I think one of the most important, and the one we always hammer home, is to just keep moving. So all of our patients know that I'm going to give you an exercise prescription based on the best available evidence from the guidelines. It's going to talk about 30 minutes of high intensity, moderate intensity exercise daily, but I'm also going to tell you that is your aspirational goal. I want you to start with whatever you can do and whatever time you have. And I recommend walking, because all of our patients can do that for every day of their life until they're, my oldest patient is 105 years old and she walks every day. And that's what I tell them, just keep moving. Humans were meant to walk and walk all the time. You don't have to marathon run, but you do have to keep moving. And people really do accept that better, because everybody can understand, walk to the corner rather than take, a car, versus, I want you to start running or jogging or anything like that. But just keep moving, start with walking, and just increase it as much as you can.
I agree with that. I usually tell patients to start by just doing 10 minutes, 3 days a week. If you're doing nothing at all, just start with that and build upon that, maybe an additional 10 minutes.
And people have, if you look at the data, the biggest bang for your buck accrues from doing nothing, the absolute couch potato, to just doing a little bit.
Yeah.
That's where you get the biggest bang for your buck.
That's right. That's also an important point in terms of moving. And here you can get a subscription to Planet Fitness for $10 a month, because we have bad weather, so you can't always walk outside. So I think that's important. Plus, we liaison with our local YMCA, and they also have, I think, a family membership for $57 a month, and they'll babysit the kids. So there are some interesting physical activity options here that I had not realized when I was in other states.
I will say a lot of health insurance programs also participate in the Silver Sneakers program. And so
Yes.
The patient's gym membership is covered for that, which is excellent. You can use the entire facilities. You may not be able to do one-on-one training, but at least I have free access to facilities. And what I've been doing now in the midst of the pandemic is sharing with my patients a lot of online resources that they can utilize. I don't know if you guys have been doing the same now that we've had a lot of the gyms that have shut down.
Yeah, that's been a big issue for us, is the shut down.
We've actually started a research project using text messaging. So we push out daily texts to them about, it's 3 o'clock. Have you done your steps today? It's just to try to to keep people connected, and B, just to remind them to keep their fitness up and their health up, because during a pandemic, that's probably not forefront of most people's minds.
But I do tell my patients that it's the calories if you want to lose weight, and it's the physical activity if you want to maintain that weight loss. So they're both
100%.
equally important.
Yeah, I think we've done a disadvantage to the American population with shows like The Biggest Loser that convince people that they can exercise away the pounds. It's all about what you eat.
Absolutely.
Exercise is absolutely vital for health and welfare and longevity and weight maintenance, but weight loss is all about what you eat.
Yeah. I always tell them 80% of weight loss is what you're eating, 20% of exercise as well.
So I want to ask both of you, in terms of the lipids, especially the cholesterol, what do you say about diet? And I'm prefacing that I've tried the American Heart Association diet, and it's not easy. So what do you say about?
Most of the cholesterol in everyone's body is genetically determined by their liver. If your liver is programmed to make 200 milligrams per deciliter of LDL, it's just going to churn out 200 milligrams per deciliter of LDL, regardless of what you eat. There are about 15% of the cholesterol in most patients comes from your diet, but most of it is just what your liver is determined to churn out. There are a few people who have genetic polymorphisms or ApoE4 carriers who are more dietary responsive, but for most of us, and this is my weird analogy, I tell them it's kind of like spitting in the ocean. It's just not going to make that much of a difference.
Yes, so for weight loss and maybe even blood pressure, changing your lifestyle is very important. But for cholesterol lowering, it's very difficult. So I end up having to treat my patients. I'm sure you do pharmacologically. You have no choice.
I tell them the best diet is a prudent diet. Don't go crazy, because literally it's not going to make that much difference to your LDL. But the medications we use absolutely will. We have to tell your liver to stop making so much cholesterol or to get rid of more of it.
And that's extremely important in patients to prevent them from feeling discouraged when they're trying to eat a healthy diet. LDL doesn't respond the way you expect it to.
I absolutely tell them that. This is your liver. You're hardwired. You were born with this. This is what it's doing, what it was told to do. And the only way to interrupt that is really with medications. And it's not a failure. These are, and I don't call them, you're not taking these because you're sick. You're taking these because I want to keep you well.
Right, exactly. Good, so we're all agreed about that.
Yeah.
Let's recap what we learned in part 2. Race and ethnicity may play a role in CV risk. African American women have higher CRP levels than other populations. Physicians should have an open dialogue with their patients around lifestyle changes that can assist with cardiovascular disease prevention. Strategies that may work include discussions around healthier food choices and working with community advocates in assisting with easier access to healthy food. Encourage realistic fitness goals, starting slow with whatever time patients have and working up to meet loftier goals.
So that's an excellent segue. Moving on to statins, because some of our patients will need to be on statin therapy. Dr. Watson, just can you share with the audience, when do you start statins for patients, whether it's primary or secondary prevention?
Well, secondary prevention is easy. The very day they present, they get high-intensity statin therapy, because what we want to do, if you're presenting with any acute ASCVD event, that means plaques are unstable and they just ruptured. When you have one ruptured plaque, you have dozens of rupturing plaques or vulnerable plaques. And so you have to try to stabilize them as rapidly as possible, and that requires high intensity statin. Now, I was a member of the 2013 cholesterol guidelines writing committee, and that's what we said. The other thing we said, though, is make sure you get them on the max intensity of statin that's tolerated. Not everybody can always tolerate the intensity you want. Try your darndest to get them on it, but if they can't, find the dose and the frequency that they can tolerate. In primary prevention, I go typically by the ACC/AHA guidelines, and I also use clinical experience and what I think the patient needs for optimal longevity and outcomes. So it's always a discussion. I'll say, this is what the data shows. This is what I think. Tell me what you're willing to do or what you think. And so it's always a discussion.
So the shared decision making.
Especially in primary prevention. In secondary prevention, I always tell them, when I give them any medication, I give them everything they need to know about it and what it's for and what I consider live longer medications versus feel better medications. And I like to make this a group effort in their own management. You get to decide what to do with the feel better medications as long as it's not harmful, but please let me decide what to do with the live longer medications.
I like that. One of the things with the newer guidelines is we moved away from treating to target LDL levels. Dr. Hsueh, do you want to talk about that a little bit? Do you agree with that?
So as you know, the 2018 guidelines do have a threshold and a number and a goal. And I can tell you in the 2013 guidelines, when we rewrote them, we sort of changed the whole paradigm of thinking about cholesterol. We used to, if you guys can remember way back when, all of the guidelines used to say, if you're at high risk, get your LDL down to 100, just do it however you have to, it didn't matter. But then in our guidelines, we said, it's not about just the LDL number, it's about outcomes and risk. So we said the best way to reduce hard cardiovascular outcomes is with statins. So the three important things we did in those guidelines was, one, we declared it is a statin world. Statins are the mainstay of every cholesterol modification therapy. Get them on the statin. The second thing we did is what we clarified intensity of statin. So in the high intensity statin, we said it was something that lowered LDL 50%, moderate intensity 30%, low intensity we didn't even bother with because it's not something we recommended. And the third important thing we did was we said, make sure you match the intensity of therapy to the intensity of risk. So if you have a high risk person, they need high intensity statin. A moderate risk person needs moderate intensity statin. A low risk person probably doesn't need anything. So again, we never recommended low intensity statins. The 2018 guidelines, so we took away all LDL targets.
Right.
The 2018 guidelines came along and I really like what they did. They sort of kept the same schema that we had put in. It's a statin world. Make sure you get the appropriate intensity statin therapy and make sure you match the intensity of statin therapy to the intensity of risk. But they also added a new level of risk called extremely high, very high risk patients. So those are the people that get on max tolerated and high intensity statin therapy plus addition of non-statins to reach a certain threshold LDL level. And I absolutely agree with that. When we wrote our guidelines, there were no studies that had ever showed the benefit above statin therapy of adding on a non-statin. But since then, there are now 3. And so we use those data to inform the 2018 guidelines. So you get them on the appropriate intensity of statin therapy according to their risk. Very high risk patients get high intensity statin therapy plus addition of non-statins to make sure they get their LDL to below 70.
So how low do you go? This is a very tricky question.
So I find it actually pretty easy. The only time I've ever felt that LDL was too low was someone who was put on a PCSK9 inhibitor and statin because of high triglycerides. Not particularly the appropriate thing to do, but anyhow, And then I got the LDL back and it said undetectable. That was the one and only time I said that's too low. Because we have to remember that all of us, unless we have some genetic abnormality, are born with LDL cholesterols around 30. And so at a time when you need LDL the most, you're making all of your cell membranes, you're making all of your hormones, you're making your skin. 30 is enough. And so I'm so comfortable with 30. I'm comfortable with lower than 30.
I have some patients that are 10 or less.
Yeah.
And I'm not sure I feel comfortable less than 10.
So,
Newborn babies who are making cells and their brains and are developing have cholesterols of LDLs of about 20, 25
right.
up to 30. So I agree with you. I feel safe there. But once it gets around 10 or below, I start wondering.
Well, so the good news is that we do have data. So from the FOURIER trial, they did an analysis in people who happened to get their LDL below 10 compared to people whose LDL stayed at 100. And they found a 50% reduction in adverse clinical events if the LDL was less than 10, exactly the same safety profile. So it was safe and efficacious. So the longer I live, I realize that too much LDL running around our systems is just not a good thing.
Right. Good.
Do you think we're being aggressive enough with statin therapy and even in non-statins in most of our patients in getting their LDLs low enough? I think that's a concern I've had with some patients who have been referred to me is when I want to add an additional agent, whether it's a PCSK9 or whether it's ezetimibe, there may be some resistance, not just from the patient, but also sometimes from the referring doctor who has that conversation that, no, it's too low, and they'll even back off on the statin sometimes. So how do you have that discussion with not just patients, but also referring doctors that our goal here is to get as low as possible, even using non-statin therapies? Dr. Hsueh?
Well, I think what Dr. Watson just said, you just present the data that it's safe. And I always tell them the newborn baby story. So I don't have any problems with going lower than 70. In fact, I think there should be some trials to address if you go lower, 50 or lower, what happens to the events.
And the ACE guidelines do recommend going below 55. So I think that's the trend in all of the guidelines. The more data we get, the more comfort we get with these very low LDL levels. And with PCSK9 inhibitors, I'm seeing so many patients with LDL levels in the single digits. It's, we're going to get a lot more comfort.
What about patient adherence? Do you, either of you, know any common, or have you come across in your career any common barriers for patient adherence when it comes to compliance with statins? I shouldn't use the word compliance, but adherence to statin therapy, and which assists them in not just reducing cardiovascular risk, but also prior to that getting your LDL to go, because that's one of the challenges I run into.
I think it's a great challenge because I have many people, even though the data doesn't suggest that, oh, I ache all over, my muscles hurt. I mean, they don't necessarily have dark urine and elevated, LDH or something like that, or creatinine kinases, but they tell me they're taking it, but I'm sure they're not, because their cholesterols are not at goal for what I give them. So I think it's a major problem.
I agree with you, Dr. Hsueh, and unfortunately, especially in primary prevention, what I've learned is that for at least 50% of all patients, the minute you prescribe them the statin, that's the minute they start plotting how to get off of it. They start thinking about how they're going to change their diet, they're going to up their exercise, they're going to do this, that, and the other, and they're going to lower their cholesterol on their own and stop that darn statin. So it's a lot of education about what Dr. Hsueh and I were talking about in the beginning, about where does cholesterol come from? What is going into how high it is, and what can we do? And again, if they know the reasons, I don't really care to make the number pretty. That's not why I'm giving you these agents. I'm giving you these agents to reduce the risk of hard cardiovascular outcomes, MI, stroke, cardiovascular death, and to make you live better and longer.
And some patients, I've actually gotten CYP enzymes because I'm not sure they're metabolizing their cholesterol. Maybe they're not metabolizing it, and they're more likely to get some kind of side effects. So then you might not be able to use such a high dose, and you have to use ezetimibe or something else, PCSK9 inhibitor in addition. So it's not everybody you just slam high dose statins on. I learned that because, in the diabetes world, give them high dose statin. Let's everybody gets atorvastatin 80 or rosuvastatin 20, and it's not always that easy in these patients.
And for those who are even very reluctant, you'll get a sense of that even just from the initial conversations. I may start lower and gradually say, oh, you did so well on this dose, let's go ahead and increase it. And, they're more accepting of that start low and go slow increase till you get to
1,000%. When I feel the pushback, I said, let's talk. Okay, I'm happy to start half dose every other day, once a week, whatever you're comfortable with, let's try that.
Let's recap what we learned in Part 3. Statin therapy is a mainstay of cholesterol modification therapy. Review the guidelines and use your best judgment to determine targets based on each individual case. Many patients struggle with adherence to prescribed statin therapy. Encourage shared decision-making and an open dialogue with patients around hesitations or reasons for non-adherence.
Women, we know that women can present differently with cardiovascular disease, and certainly, as we mentioned, that there are gender-specific risk factors, pregnancy-related, and some inflammatory conditions like lupus and rheumatoid arthritis, which we know are much more prevalent in women compared to men. Do you think that we are doing enough as far as including women in trials, specifically lipid trials, because we know there's not a great representation in women in overall cardiovascular trials? What about lipid trials? How have we done in that arena, and what can we do to improve that? Big question.
And crummy for women, for minorities and ethnic groups. And I gotta say, someone who enrolls in a lot of trials, it's not easy at all. One of the things that I do know, and I think Dr. Hsueh can agree with me, if you want to enroll people that look like me, you need to have people that look like me running trials, right, Dr. Hsueh? So
Yes,
I think we need more women as principal investigators, et cetera, but it's not easy. There is some mistrust, and there is, it's difficult. I think the way trials are run, and Dr. Hsueh, you help me on this, I think you would agree. For instance, there's so many rules about what you can and can't do. Like, for instance, I can't pay for childcare to help my participants come in. And that then is essentially disadvantaging women.
Yeah.
I can't, so a lot of those things are just structural sexism.
Yeah, but childcare is really important. So we actually had, when I was in Texas, we had hired people. So when the subjects brought their children, we had babysitters there on the
our IRB would not let us.
Yeah, you have to do something like that. Absolutely,
especially since women tend to be the primary caregivers of the entire family, and sometimes are the sole breadwinners of the family. So if our goal is to include them in these trials and learn how these medications affect them and how they respond to them, we've got to make it easier for them to be able to participate in these trials.
Right. But then I think even hiring or recruiting men is difficult because I'm healthy, I don't need to do this, that sort of thing. So in I think any race, the women tend to be more health conscious than the men, and the women are the one that are pushing the men just to get an exam. So both genders are very difficult to recruit for these kinds of things.
Yeah, for different reasons. You're right. Most of the males will come because their wife or their girlfriend made the appointment for them. Otherwise, you won't see them in the office.
Exactly. That's exactly why they're there. My wife made me come.
So we have the challenges with getting women into the clinical trials. From the clinical standpoint, do you think that women are being offered lipid therapy at the same rate as men are? Are we doing enough? knowing that we have the information, we have the data, what about the clinical practice? Dr. Watson?
I sure hope so. I do have to acknowledge that there were years where there was a lot of noise in the field saying, oh, women don't benefit from statins, we're over treating women. And that really did foment confusion. And what happens when patients are confused? They do nothing. And that was disheartening for me. But I think we have the data that it's risk that should drive our treatment decisions, not sex, not gender, not race, not ethnicity. It's risk. If you're at risk, you need a statin.
So here's the question. What do I do with the premenopausal lady with a high cholesterol who has diabetes? Type 1 or type 2?
So she's a high risk
menopausal lady, because we know that estrogens make your liver handle cholesterol a lot different than if you didn't have estrogen. And
right. But if they're at risk, they need therapy. And I discuss contraception and teratogenicity and all the concerns. But for many patients that are premenopausal who we treat, and as soon as they're ready to think about having kids or breastfeed, we stop the drug and monitor them. But while they're not, we want them protected.
When would you start it because I see patients with obesity, type 2 diabetes, or even type 1 diabetes when as soon as they're adults, 18 years old, 19 years old.
That would be a case where probably measuring coronary calcium would help you a lot.
Exactly. So this is, you two both do all this prevention. I have gotten a coronary calcium score when I've asked for it, only in 2 patients, because they said their health insurance will not pay for it. Dr. Hsueh, they told me it's going to cost me $600 to get it, and I just can't afford it. So what should I do? So
fortunately, the cost has come down so much. Out of pocket, even in Los Angeles, it's about $100 now.
Really?
But that's too much for a lot of patients. So we then do prior auths with their insurance companies. And it takes up way too much of all of our times, but they usually relent.
So what if you had, I had a couple of patients who couldn't afford the coronary calcium score, but they did have normal HSCRPs. So what would you do?
So that's another tiebreaker. Coronary calcium is better than HSCRP, but it's another tiebreaker. So you might feel a little more comfortable waiting in that person. But again, I like looking at the vessel rather than just a marker.
I agree.
And even here in Atlanta, calcium scores are just $100. So a lot of patients have been able to get them. And again, especially in those who may have a family history, those who you're on the fence with. But you're right, Dr. Watson, for some patients, even that $100 really is just financially a significant constraint for them. And you just keep having that discussion about other risk factors that are modifiable and other tests that you can do to screen for subclinical atherosclerosis.
Yeah, agree.
I have to talk to our cardiologist. Maybe they can get it cheaper.
Yeah, and I don't know of any insurance that covers it. It always is usually here, at least an out-of-pocket expense.
It is, okay. So we need to just get them for a cheaper price through the hospital.
Yeah. All right, well, the last segment of what I wanted to touch on is underserved populations, and we mentioned the increased ASCVD risk in that patient population. Certainly they have a lot more of the risk factors. They tend to have higher cardiovascular events in that patient population. What can we do to bridge the gap in cardiovascular care in underserved populations?
Well, many studies have shown is that when people adhere to guidelines, disparities decrease, and sometimes they go away altogether. When we make subjective decisions about who should get what or what should get what, then a lot of implicit bias can come into it. But when we go objectively down the guidelines, if you make the criteria for this, then you get treated with that, then a lot of disparities go away. So one of the things we can do is really adhere to the guidelines.
I totally agree. That's why, as I mentioned earlier, with Life Simple 7, it's kind of an easy way. You should exercise, you should lose weight, you should cut your carb intake down and keep your blood pressure in a good range. And I think for us, I mean, having now like the local pharmacy or grocery store, we can actually get your blood pressure taken. It'll measure your weight. They do all these things. And I actually tell my patients, if you can't do this at home, just next time you go to the grocery store, just get these measurements and write them down and, you know, let me know what they are. Just call them in or my chart me, something like that. So that's useful. And I think I've had to do it more now with the telehealth, because you can't actually get that out of the you know, get the patient to get those things in your office.
And some insurances actually will even send patients glucometers and blood pressure monitors as well as part of their benefits package for their insurance. So I utilize that as well. When we weren't in the midst of the pandemic, if there was any question about blood pressure readings, I would ask them to take their blood pressure machine to their local fire station and they can calibrate it for them, right?
Oh,
so
good.
The office, yeah. So I agree with you. I think some of these techniques that we can recommend to our patients, especially those who may be restricted, whether it's from resources or financially, to help them bridge that gap so that they are at least closer to an equal playing field when it comes to healthcare.
Right. And here we actually are lucky because the state pays for a lot of home health visits. So you can have somebody come and take those measurements on a regular basis. And I think for some diseases, especially like heart failure, you can decrease admissions if you have a home health person helping that patient along. The other thing is getting their pills in some kind of order. So pharmacies give you the little pill packages, so that helps a lot. And patients don't have to sort it out themselves.
Yeah, I have found a number of my patients are taking advantage of that. So the pill packaging service, or if they don't want to buy the pill bottle or the pill box for themselves, so they have sort of daytime and afternoon packages. Right, well, I wanted to give you both the opportunity for any closing remarks that you'd like to offer when it comes to, that you'd like the audience to know when it comes to lipid management and ASCVD. Dr. Watson, I'll start with you first.
I just think one of the things we always have to consider is how we can reduce risk. And for so many patients, the correct answer is decrease the LDL. And again, there just aren't that many patients who you'd ever say, yeah, I don't want that LDL down anymore. But there are some maybe, but for so many patients, the correct answer is reduce the LDL. So let's try to do that and get our patients to do better.
Dr. Hsueh?
I would agree that cholesterol lowering to decrease risk of heart attack, stroke, peripheral arterial disease, all of those things, even CKD, chronic kidney disease, even NASH, non-alcoholic steatohepatitis. If you lower the cholesterol, it helps all those kinds of diseases. And I think it's all an inflammatory process. And cholesterol is a terrible pro-inflammatory factor. And so I think if we can lower the circulating levels, all the better. So I would agree, but I do think some of the other risks that promote inflammation, like we were talking about, hypertension, obesity, diabetes, they also have to be addressed. And Dr. Watson mentioned patients with lupus and rheumatoid arthritis. I think, you know, those patients don't die of their autoimmune disease, they die of coronary artery disease. So yeah, so I think there's many groups that fall under the category of high risk, and we just have to identify them very carefully and try to deal with them. They're all their risks appropriately.
I couldn't agree more. Well, thank you very much, Dr. Watson, Dr. Hsueh, for this excellent discussion. I learned a lot, and I know our audience members are going to take a lot away from this conversation as well. Thank you very much.
Thank you so much for having us.
Now let's recap what we learned in Part 4. Women can present differently with cardiovascular disease, and certain risk factors are more gender-specific or more prevalent in women. Women are often underrepresented in cardiovascular and lipid trials. Less women serve as principal investigators, and women may face barriers in participation, such as lack of available childcare or busy schedules. There is increased ASCVD risk in underserved populations. Adherence to guidelines can help reduce implicit bias. Identify high-risk patients carefully and manage their care appropriately. Thank you for joining us for today's presentation.